Cast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone. My name is Elise Sweeney Anthony, and I'm the Director of Policy at ONC. We want to thank everyone for joining us here today for our second meeting on the 21st Century Cures Act, Trusted Exchange Framework, and Common Agreement. As many folks know, the 21st Century Cures Act calls for ONC to develop or support a Trusted Exchange Framework and Common Agreement in support of information moving and data liquidity. Today at our second meeting, we're going to have a chance to hear a summary of some of the public comments that we received during the public comment process, as well as some thoughts on an analysis that was produced around some of the existing networks that support Exchange. Before we get started, I want to take the opportunity to provide a couple of housekeeping notes. The meeting today is being recorded. There will be opportunities for you to submit questions online. In addition, we do know that today is the start of a religious holiday for some, so we do plan to end a little bit early if possible. And with that, I do want to turn it over to our National Coordinator for Health Information Technology, Dr. Don Rucker.
Hi, welcome everybody. We certainly thank folks' participation, and we thank folks' participation in the public comment period. We are just appreciative of all of the energy and work there. We recognize people have been working on interoperability and in particular trusted exchange frameworks for quite a while, and we acknowledge the vast amount of work going forward, and really this is we see it as the next step in the 21st Century Cures Act, and we, I think, look at 21st Century Cures, and I believe the Spirit Congress who almost unanimously passed this act, looked at it as a way to increase interoperability throughout the country. It's worth noting that the Trust Exchange Framework are one of the big ways of doing that. There are other ways, the open APIs without special effort, so there are some other ways of doing that, but I think we'll move pretty quickly here and get to the public comments, then maybe reflect on sort of what we've heard a little bit and kick it off to a formal analysis. So with that, in the interest of moving things along, we're going to kick it off to Lee Stevens, who has been at ONC a long time and has worked on many of these policy issues for quite a while.
Thank you, Dr. Rucker. Thanks for joining us today, and wanted to walk through some of the public comments that we received. These will be posted at healthit.gov/trusted exchange, so you will be able to see the full feed of that. We do have one little housekeeping issue that we wanted to show you how to submit or ask a question. And these are the directions here. Since the lines are muted, we're going to ask so that we can keep a running tally of all the questions. If you can submit your text question and comments using the question panel that you'll see on your screen, we will try to answer as many of those during the public comment period today as possible. Next slide, please. Okay, a little bit of background here on the public comment. As many of you may remember from the first meeting, on July 24th, we opened public comment, and we had it open until August 25th. We received, through a variety of methods, which really included letters that were submitted to the national coordinator, through comments sent into the ONC JIRA system that many of you would see, and from the comments that we received in the first meeting, we really tallied that up to be, we received about over 115 comments, and many of those comments that counted as one came from associations that represented a much larger number of stakeholders. We received, of course, general comments as well as comments in the areas that we had sort of tagged, including standardization, transparency, cooperation and non-discrimination, security and patient safety, access, and data-driven choice. All of the comments, as I mentioned earlier, will be available on healthit.gov/trusted exchange. Next slide, please. So to give you an idea of some of the comments that we received, we certainly heard clearly that we should be careful not to disrupt or duplicate any existing efforts. We heard that it's important to focus requirements on critical areas of inconsistency across existing network agreements, which is very important and really probably the purpose of parts of the Cures Act. But on the other hand, we heard in some cases that we need to ensure enough flexibility. So these are sort of competing points of view that we have to address, and we have to sort of strike the right balance to really allow the market to blossom while creating interoperability at the same time. We heard very clearly reduce the cost and technical barriers for participation for small providers, and really a message to establish a floor, not a ceiling for data exchange. Next slide, please. In the general area, we heard that there should be an enforcement mechanism for participants failing to meet requirements. As we've heard from the very beginning of the Office of the National Coordinator, quite frankly, going back about 12 years, we should be careful not to limit innovation or competition, establishing clear definitions of terms, eligibility requirements. As we've heard many times before, the issue of patient access to health data. There does seem to be a growth of interest among consumers now that the message is out. People understand that it is available and they do want to get to it now. And we also have heard that we have to recognize the cost and time that's required to modify existing agreements, and that'll be important to us going forward. Next slide, please. In the area of standardization, we heard very clearly that we should leverage existing standards and implementation specs. We should focus on the standards for transport, content, vocabulary, security, and semantics. We should make sure that we are aligning the TEFCA and the ISA, and that will be very, very important to us to moving forward, as that's part of a more clear direction from ONC moving forward from this point. Of course, we always hear a lot about patient matching between networks, and that was the case in this situation as well. Next slide, please. We heard that we should expand the set of standards and implementation specs, reduce the role for government in the furthering of adoption of standards. And so, as you see here, some of these comments, they do start to conflict. I think that generally the direction that is laid out in the ISA tends to have been accepted by the majority as a good way and approach to understand what direction ONC is heading in, and it gives a clear expectation around standards. We did also hear to make improvements to the CCDA and include stronger identity proofing requirements. Next slide, please. Defining the boundaries of where the transparency requirements apply and what the limitations are was a point that was made. We should develop guardrails and we should avoid attempting to draft detailed service level or network agreements, establish the requirements, including publicly posting data sharing agreements, use cases, standards, implementation guides, exchange metrics. A lot of those pieces are going to be very important for people to understand what kind of contracts they're entering into and agree in these agreements. Next slide, please. ONC should not make lack of sign-on to the TEFCA de facto information blocking. Ensure networks meet baseline requirements for their governance approach. We heard that we should really have enough flexibility for local policy decisions, which of course is important. We heard that we should provide clarification on whether the TEFCA would require participants to openly and transparently exchange with all parties. And also the push for greater control and transparency for patients on how their data is exchanged. Next slide, please. So some of the examples on cooperation and non-discrimination that we heard, we heard support for the principle broadly. We heard some specifics, including mutual commitment to assist other parties in fulfilling obligatory or regulatory obligations under the Cures Act, clear confidentiality protection for proprietary information, a mechanism for stakeholder collaboration and dispute resolution, safe harbor provisions to address antitrust and collusion concerns. We heard support for an approach that establishes a default expectation that signatories are sharing data. Next slide, please. Ensure participants' responsibility includes provisions related to the governance and operations of the trust arrangement. Make sure that the provision is structured in a way that similarly situated participants must treat each other equally and not discriminate against each other. I think these really reflect the fact that people were putting great thought into their comments and that they submitted. And these are all very important points as we move forward here. Next slide, please. Security and patient safety identified as an important principle of the TEFCA, very clearly something a lot of folks are thinking about. Participants should be required to notify each other of potential unauthorized access, use, or disclosure of message content so that all parties can fully determine their legal obligations. ONC should collaborate further with other federal agencies to identify methods to ensure the private sector adequately protects controlled, unclassified information that could be transmitted through their exchanges or networks. Next slide, please. Here getting into a little bit more of the detail, and I won't read every line of this, but having break the glass provisions for emergency access, these types of situations can become very important during national disasters like we've seen recently. There was a comment around cyber liability insurance, the appropriate flow down of it, all provisions to the relevant participants. We heard about establishing data review standards, really looking at future biometric solutions, tokens or keys for two-factor authentication, flexible approach for identity management. Much of this you can see in the raw comments that we'll post, a lot of thought that went in here as well. Next slide, please. A little bit more on from the access point of view is it's an important principle for TEFCA that certain components may be out of scope for some networks arrangements and should not necessarily be required. There was concern around the definition of easy in the context of the principle about what easy means as it relates to access. If defined too leniently, it could expose industry to privacy and security vulnerabilities. It's an important point. If it's too stringent, it could actually reduce the ability to exchange data. So that's going to be a place where we're going to have to sort of carefully navigate to make sure that we're hitting the right balance. Of course, credentialing and validating must be scalable. Next slide, please. TEFCA should be flexible and secure in providing access. TEFCA should be leveraged to improve a patient's access to their health information. Really a request for the clarification of the use of caregiver in the context of this principle. who exactly is it referring to? Is it a patient's clinician, family member, or other designated care guardian, or both? So that's something for us to look a little bit further at the extent of caregiver for this provision. Next slide, please. Data-driven choice. We heard that it was possibly outside the scope of the statutory language of cures, and we also heard some questions about clarification on the scope of this principle. And a part of that in thinking about this is that data, I'll describe this and I'll let Dr. Rucker describe it a little bit more as he thinks about it, and that enough data can be exchanged so that patients can make and consumers can make good decisions. Providers are able to make decisions based on trends that are seen in data exchange. We heard very clearly that we should encourage public health agencies to develop tools and processes for bidirectional communication with providers. ONC should charge the HIPAC with providing recommendations on the public benefits and risks associated with the sharing of secondary data. Next slide, please. So that is sort of the end there, and I'm going to hand it over to Dr. Rucker to give a response.
Lee, thanks. That was well. First of all, thank you again to everybody who took the time to submit comments. As somebody who has submitted multiple public comments when I was in the private sector, I know well how long these things take to write. And certainly for the larger organizations, what a team effort putting these things together are. And I'll tell you, one of the surprises in coming to the federal side of things is how seriously these comments are taken and how much process there is around them. Frankly, when I was on the other side writing them, I wondered whether anybody was ever going to read this. So I assure you that certainly my experience in Health and Human Services throughout the agency has been CMS, obviously ONC, that these comments are taken with extreme seriousness. And I would say of the things that Lee has just, I guess, summarized, and they're all available online, right? So again, public comments. Every one of them has large grains of truth in them, even the ones that are seemingly contradictory. I think as we look around the room, you know, they reflect the tensions of privacy versus sharing, structured data maybe versus less structured data. They reflect the tensions of the costs of capturing data, both at the programming side of the thing, at the provider entering it into the system, and then at the system, whether that's a one-person practice system or, you know, a much larger entity, how to move the data. A couple of specific thoughts here. First of all, I think on some of the trust and security and the secondary uses of data question, I just want to emphasize that these things are covered by HIPAA, right? So we're not changing the, other than with one specific potential exception, which is also the law of HIPAA today, we're not actually changing any privacy or security rights with this. You know, these are fully covered under HIPAA, these transactions. HIPAA today, and as always, if a patient at some point wants to take their record, download it directly, the patient then can do with that data as they wish, whether that is on, you know, something like a CD, or whether that is going to an app that might even potentially be quite questionable. That is the patient's right under the law today. Wanted to make sure everybody understood that. As we look at this and look at the intent of Congress, I think, and we're seeing this in some of the comments, Congress clearly, and the Cures Act is a pretty fresh law, right? That was December of 2016, right? So this is less than a year ago. I think they were seeing that there were big deficits in interoperability that they wanted to address. And so as we look at our work and extend on the work already done, we want to make sure that these trusted exchange frameworks, have somehow that there are provisions, and maybe some of this is more on open APIs, right? There's a little bit of a duality on how this information may be transmitted, but that we provide under the Cures Act access for patients to directly get and control their data, I think is very important. I think the other part of it that has been missing historically is some of the payer, some of the population health type of data. This is often one-off interfaces. So the folks who are providing care for us, supervising care for us, whether you call that population health or payer, that they have access to data. That's obviously not classically been the business model of some of the exchanges, and so we're working with folks on that. And finally, to a couple of the comments, as we look at so those are some of the broader issues of interoperability. As we look at some of the specific interoperability issues, obviously most of the discussion of interoperability has focused on provider to provider types of things, as opposed to consumer or to payer, those type of transactions. The important part, as the policy is through high deductible health plans, through a number of measures for patients to be able to shop. We also have to think about, be very rigorous that as many providers as possible are included in this. So this is just not large providers with large enterprise systems that often today do have some very good mechanisms to share data. We have to think, if you as a patient want to go to an urgent care clinic, or you want to not pay thousands of dollars for an ER visit and want to go to a freestanding ER that maybe offers you a different profile and price point of care, or if, as at least one large national insurer is now requiring you to go to an outpatient unaffiliated imaging center to get your MRI or CT scan, that these competitive forms of data also get into these networks. And so we're very sensitive that we not put in language to prevent that type of very subtle but ultimately profound loss of access to data, or just lack of access to data. So those are a couple observations on what Lee has outlined. And again, I think on behalf of everybody at ONC, including some of the people who have spent hours and will spend more hours going through every one of these comments, thanks again. I think now we turn it over for some very specific formal analysis. This is done by an outside contractor, and this is really, the goal is to make sure that as a public agency, we are as rigorous as possible before we get to the rulemaking that Elise and Steve outlined, and how we look at this and look at the part of use cases. Just to check, there will be other comment periods as this process goes on. Maybe Elise, you can talk to that.
Yes, absolutely. For the comment agreement process, our goal is to provide multiple touch points with the stakeholder community. The comment period that just closed is just one opportunity. Once we have thought about and put together a draft for consideration, we plan to release that and share with the public for their thoughts, and then would release a final with a goal of that happening sometime in 2018 is when the final would be released. So yes, there'll be multiple opportunities for touch points. And the common agreement, again, Cures lays out the process for us to consider that. Some of that process is would be handled with the rulemaking in terms of how folks sign on. And then there's a piece of it that we would be working with the community and then release from ONC.
Yeah, and in that spirit, obviously the Cures Act has a lot on open APIs. That gets to some of the data handling issues we talked about here. We think that the new RESTful, to use a very computer term, it sounds sort of non-computery, but it has a very specific computer science, meaning the JSON standards and FHIR, some of these new technologies, which are works in progress, and we're aware of that, and we'll consider that may offer some unique opportunities here as well. So just for folks who may not be thinking, maybe thinking purely about the framework as these one and done means, to some of the earlier comments on having multiple options for data, just want to make sure everybody's thinking about that as well. Thanks.
I think now we're going to turn it over to Corey Mertz to talk a little bit about the detailed analysis of the current trust agreement.
Great, thanks, Lee. As Lee mentioned, I am going to be reviewing a detailed analysis we did for ONC recently. These slides I'm going to go through are summary slides, and the actual detailed analysis will both be posted on healthit.gov/trustedexchange. So you will have the ability to go online and access all of these materials here. So next slide. So the analysis is on seven of the kind of trusted exchange organizations that are out there and operational today. We focused in on the ones that are moving information today, have their policies and procedures in place currently for this analysis. So, we'll be running through kind of the trends and summaries across these 7 organizations, and this is what the detailed analysis that will be posted soon covers as well. So next slide. So for the analysis, what we did was gather up all of the kind of foundational elements that these trust arrangements use as part of their trust framework, so legal agreements, the policies and procedures, technical testing programs, bylaws, accreditation programs, and use cases. We took all of these, we gathered all these materials together from these 7 organizations, reviewed them, read through all of those materials, and that is what the kind of findings of this analysis are based on. We also shared the findings with all these organizations, gave them a chance to review and provide input on the findings. So just a quick background on how we put this together, and next slide, we'll start diving into the analysis. So as we look through the documents, we kind of identified 8 overarching trust categories where we saw commonalities and kind of consistency, or at least similarities across the organizations, right? Like all of these types of trust arrangements have provisions that address these things. While the details vary across them often, sometimes they're similar, sometimes there's differences. These are areas we felt like it really made sense to look across these organizations. There, a lot of these organizations certainly cover additional areas, but these felt like the kind of core areas that we needed to look at for this analysis. So we have the 8 kind of overarching trust categories. We're going to run through all of those in this presentation today. And then we identified 16 subcategories underneath those overarching categories. So next slide. We'll get going here on the purpose and scope of arrangement. So if we can go to the next slide. So, as you think about these organizations, it's important to remember that each of them has kind of a unique set of goals, set of stakeholders, and the time period in which it was founded, which drives the kind of commonalities and differences across them, right? They all have stakeholders that are driving the kind of priority setting and goals and types of exchange that they're trying to enable, because their stakeholders came together, said, hey, I need a way to address this particular use case or to do this particular activity. And that's where these kind of trust arrangements all came from. So each of them has kind of a unique set of goals. But I think where you see the kind of common characteristics across them is a few areas, right? So, a key component of any trust arrangement is establishing rules of the road. And these rules of the road set the bar for what participants are going to be comfortable with as far as the policies that need to be in place that they are assured other participants are following, so they're comfortable exchanging health information with one another. The second key component of all of these trust arrangements is establishing technical specifications to actually move the information so that everybody's using common and consistent technical specifications, and sometimes technical infrastructure as well that supports those technical specifications. And the third kind of common component across all these is the accountability mechanisms to really verify that the participants are following the rules of the road that the trust arrangement has established, and also that they're following the technical specification that the arrangement has established. And each of the organization has set kind of their specific bar and unique bar for what those, what it means to trust one another and what the technical specifications and accountability bars need to be. And that's based on, the risk tolerance of the participants, the type of exchange being enabled, the permitted purposes of exchange, and a number of other elements that we're going to be running through here. I'm not going to read through the goals, but I think it's definitely helpful to take a look at these. And on the next slide, we have the other kind of three goals. This is all in the analysis document, as I mentioned. But I think it's really helpful to look at this and think about this, because the goals and why these organizations were formed definitely drive a lot of the kind of flow down and other pieces about how they're kind of structured and arranged themselves. So next slide. So one of the kind of key things to look at across these organizations is the scope of exchange that they support, and this varies across the arrangements. You see different approaches here. So 5 of the organizations support query and response, 3 of which support directed query and response, and 2 of which support distributed queries. 5 of the organizations support push, can we go to the next slide? Great, thank you. And the 6 of the 7 organizations are focused on enabling exchange between providers and other healthcare organizations. And 3 of the organizations support mechanisms for patients to access their information. And 1 of those 3 is solely focused on consumer or patient-mediated exchange of health information. So again, the type of exchange that they support makes a difference in the policies and other pieces that they're going to have to put in place to support that and enable trust amongst the participants. So next slide. So the approach to establishing trust across all these organizations, there's one kind of foundational element that they all have built into their approach, and that is a legal agreement that all their participants have signed. Typically, these are multi-party agreements where every participant signs the same legal agreement, and they're all bound to one another through that multi-party agreement set of requirements. Now, after that kind of baseline legal agreement piece, you see a lot of differences in the way organizations have selected their tools that they're going to use to create their trust foundation. So you see some of them leverage accreditation, some use participant data exchange testing, some use certification, self-attestation, and then the vast majority of them have operational policies and procedures that really define at a more detailed level some of the requirements that are put into place through the legal agreement. Typically, those policies and procedures are easier to modify and have a lower bar, for updating and modifying over time versus the kind of legal agreement that every single participant has to sign off on. So kind of amongst this, like the second bucket of tools, as I mentioned, you see a lot of variability. Different organizations are piecing together different tools to create their trust foundation. 1 of these 7 uses accreditation, 2 have participant data exchange testing requirements, 3 use certification, and 6 of the 7 have operational policies and procedures that they put into place. Next slide. So, another common and central element to all of these trust arrangements is a formal governance process. So all of the organizations have some overall governing body that sets the overall, is responsible for overall governance and strategic direction of the arrangement. What that body is called varies across them. For a lot of them, it's a board of directors. Some it's some sort of leadership committee, and again, the names vary, and the number of participants, the number of people on it varies. But the vast majority, it's the makeup is the participants of the arrangements, and the only folks who are allowed to be on the kind of board of directors or leadership committee are participants in the arrangement structure. Underneath these kind of board of directors, leadership committees, you typically find standing or ad hoc committees that provide input and feedback to the board of directors. One unique thing you see some of these organizations, some of the arrangements do, is they've established advisory boards. And the goal here is really to provide broader stakeholder feedback to the board of directors or the leadership committee. Sometimes you see it these kind of advisory committees, they have a different role than the standing or ad hoc committees. And typically it's to bring in a broader set of voices. Obviously with any kind of committee, any leadership committee, you can only have it be so large and still have it effectively work. I think a lot of the times these advisory boards are put into place to address that desire to get even broader stakeholder input, but also that recognition that you have to balance, operational needs and the limitations on the number of people you can have on any sort of, decision-making body and actually effectively get things done. Lastly, an important piece to keep in mind when you're thinking about the governance structure of these arrangements is that they all have processes to modify and evolve their requirements over time. So these are not static organizations that set requirements, 2, 3, 4 years ago when they were founded. They all are evolving their processes, and some of them are actually evolving their processes right now. And that reminds me of one important point I want to make about this analysis. Everything in it is based on the organization's current policies and procedures. As I just mentioned, some of these organizations are modifying their policies and procedures right now, but we focused on what is live and operational today, not on pieces that are coming in the future. So just an important point to keep in mind. So next slide. So moving on to the second category, which is permitted purposes for data exchange. Next slide, please. So across the arrangements, you see different permitted purposes that are, this establishes how participants can use the data that's available through the trust arrangement. So this is kind of the broad bucket. These are all the different types of permitted purposes you see across the trust arrangements that we analyzed. The first three are really kind of your standard HIPAA, TPO, treatment payment operations that you see. And then after that, you see patient access, consumer-mediated exchange, permitted purposes, care coordination, public health activities, and authorization-based disclosures. So again, this is just a broad bucket of what all these organizations, when you look across, this is, one of the organizations does each of these, at least, and has it as a permitted purpose. So next slide. The kind of common element you see across all of the trust arrangements that are focused on, provider-to-provider exchange is that treatment is a permitted purpose for all of those organizations. So, that's really the kind of foundational element that each of these organizations enables exchange for. The other thing that you kind of see uniquely around treatment is that some organizations have differing policies that apply to exchange for treatment only versus other permitted purposes. So for instance, that can be requiring reciprocity around treatment. So for instance, if I query for data, I also have to respond to other participants who query me, who want to query me for my data. And you also see some provisions around not being able to charge fees or put additional requirements, additional kind of legal requirements or policy requirements that other participants have to meet to exchange data with you. So that's just a unique element you see some of these organizations establish around treatment permitted purposes. There's one organization that limits permitted purposes to treatment only. Most of the others have a kind of broader set of permitted purposes they allow at this point. And and this is going to be a theme I'm going to talk about through a number of these. But one of the other things you see that's kind of interesting with permitted purposes and some of these other areas is the way trust arrangements have defined and applied permitted purposes. So some set a single set of permitted purposes that applies across the whole trust arrangement. So that's really saying, okay, here are the set of permitted purposes that our kind of arrangement, our rules of the road, and our technical infrastructure can be used for. Some do it at a use case level. So when they have multiple use cases, they could have different permitted purposes across those use cases. And one of the arrangements actually allows regional variation across permitted purposes, where sets of regional participants can establish more or less permissive permitted purposes for data exchange. Next slide, please. So permitted participants. Next slide. So this is another area where you see kind of variability in the approach across arrangements, and you can kind of summarize it to kind of two differing approaches, or I like to think about it like bucketing into kind of two ways that these arrangements think about permitted purposes. Some define specific types of entities that can be permitted permitted participants. Sorry. For instance, Nate looks at consumer-facing applications, and they have their set of they define what a consumer-facing application is, and what it is to meet that. Then you see Commonwealth. Typically, their participants are health IT developers or other aggregators of connectivity. So that's kind of the model where you see arrangements saying, here are the type of entities that can be participants in our model. And the kind of other approach you typically see across these organizations is more of a general setting of criteria that have to be met to be allowed to be a permitted participant. And the eHealth Exchange is an example of this, right? So they have five general things you have to do to be allowed to be a permitted participant. So first, you have to be a valid legal entity. Second, you have to be able to govern your network. Third, you have to be able to sign the DRSA. You have to be able to enforce slowdown, the DRSA slowdown provisions on your participants and your end users, and we'll talk about slowdown later in this presentation. And you also have to be able to pass applicable testing requirements. So again, these are these kind of two different approaches that you generally see across the arrangements, the kind of setting specific criteria that an entity has to meet, or kind of setting, here are the types of entities that can participate in our arrangement. Secondly, again, similar to the permitted purposes for data, you see different ways that permitted participants are defined. Sometimes it's defined at the arrangement level. Sometimes it's defined at the use case level. So just an interesting kind of nuance there. And the other thing I would just note that I think is important to keep in mind when you're thinking about the concept of what a participant is in these arrangements is that there's variability in how they've kind of constructed that concept. Take care quality as an example. They have this notion of a care quality implementer, and underneath implementers can be care quality connections. So the implementers are typically aggregators of connectivity, like HIEs, health IT developers, other types of entities like that are bringing a bunch of providers and other organizations together under them. And then, those types of entities can be connections, care quality connections underneath an implementer. And then even within there are different roles that an entity can be at play. For instance, in the query implementation use case they have, you can be a query responder, you can be a query initiator, you could be both those things, you could be a record locator service. And depending on how you kind of set yourself up as a role and as a participant and what role you play around the kind of query initiator, query responder piece, it changes what kind of requirements are placed on you. In direct trust, for instance, there are kind of three concepts that generally apply. There's the kind of HIS, there's a certificate authority, and a registration authority. Again, depending on which of those kind of types of role you are playing within that framework, you have different set of requirements that is placed on you. So again, I think it's just an interesting concept that's important to keep in mind as you're thinking about these. And I think the other thing I would just note is that there are the other kind of broad difference or kind of variability to think about is the focus on who a participant is. And I've alluded to this a little, but some of the organizations are more focused on aggregators of connectivity. And some of the arrangements focus on both, aggregators of connectivity as participants, but also allow providers and other entities like that to directly be a participant, which in that case would mean, signing the legal agreement and all those things, rather than kind of falling under one of those aggregators of connectivity. So, next slide. Next slide. So this is the identity proofing category. So I think the most important thing to keep in mind here is that all of these arrangements this is really a key component for all of these arrangements, right? Is establishing the identity proofing and authentication requirements that their participants have to meet. So they all have policies around this that apply to their participants and have to, and end users accessing the systems through there. I think the main important thing to keep in mind here is that while there are often similarities in the kind of maybe the technical approach or how they're trying to go about this, there are underlying policy differences across the arrangements that even when they are using similar technical approaches, don't make them work together. For instance, a lot of the organizations have different certificate policies, which, and you also see varying levels of assurance requirements for identity proofing. Some look at the NIST requirements, some leverage the Federal Bridge cross-certification requirements. It really varies. I think the key thing to keep in mind here is all of these organizations, focus on this and it's a priority, but the kind of details of how they've gone about it vary, and that can create some challenges if you're, looking across the organizations. So, next slide. So this is the next bucket on the technical approach and infrastructure. So next slide. So this is really thinking about the kind of technical framework that the arrangements use to enable exchange across their participants. The kind of first component of all this, right, is establishing the rules of the road. That's a lot of what we've talked about so far. That's the kind of first core component all of these arrangements have. The second piece is really the establishing the technical specifications and any technical infrastructure that's required to enable exchange amongst their participants. So each of these arrangements has technical specifications that they require their participants use to exchange with other participants on the network. Again, this is one where you see the variability that I've talked about in the permitted purposes and permitted participants, that some of the arrangements tie the specifications to specific use cases while others set it at an arrangement level. And the other thing that's just important to keep in mind here is that the arrangements have varying technical architecture approaches. So some are, federated, some have centralized components, but also have federated components. So the technical architecture across these organizations varies, and that drives some differences in how their policies are structured, what they're able to do from kind of a network and reporting perspective as well. So next slide. So this slide outlines the infrastructure that the 7 organizations use. And again, this all flows down from everything else we've talked about so far, right? So different organizations have different infrastructure based on the type of exchange they're trying to enable, based on the policies that make up their organization. So you see the variability. It really builds up from everything else about the organizations and their kind of general approach and philosophy to enabling exchange amongst their participants. Directories are kind of a common component across a number of them, but again, there's different approaches that each of these organizations takes to enabling exchange and different infrastructure components that they have in place to make that happen. So just important to keep in mind. There's more detail on all this in the analysis document. So I'll encourage you to take a look at that to get down into the weeds on these areas. So next slide. So the next category is cooperation and non-discrimination. Next slide. And I think you heard some of these themes in the comments as Lee was going through them. Some of the arrangements have provisions focused on cooperation and non-discrimination, particularly limiting the abilities of participants to create additional requirements to exchange data with other participants. And you also see some of the arrangements have policies aimed at preventing discrimination in the exchange of data with other participants. So, a good example here is around care equality. So they have these policies around non-discrimination and similarly situated participants. And the idea here is really to prevent a participant from treating another participant in a different way. So an example would be if you allow, if I'm a participant and I allow queries for payment from, one payer under a set of terms. If there's another payer that wants to query me for payment purposes and they are willing to meet similar terms and requirements that I've established with that other payer, I can't discriminate against the second payer and say, no, I'm not going to exchange with you under similar terms as this other payer I'm willing to exchange information with. That's kind of the approach that they've taken. They define carrier quality in particular, defines these provisions at the use case level. And another example of, another organization's attempt to establish kind of cooperation and non-discrimination provisions is direct trust. They have prohibitions on intentionally preventing or delaying incoming or outgoing conformant direct messages. So, when you're exchanging with another participant on the direct trust network. So, two examples of how organizations do this. Organizations do this in different ways. Again, some of them establish it at the use case level. Some of them set it in their kind of broader legal agreement that everyone signs onto. And so you see variability in approaches here, but it's definitely something a number of these organizations have built policies into their arrangements on. But some of them do not have provisions like this as well. So, next slide. So this is the kind of third leg of the stool around accountability. And so there's multiple components to accountability. There's kind of the more technical side of accountability, and there's also the policy side. So we're going to start with talking through the more technical components of accountability. So I've mentioned some of these points earlier, but just want to kind of hone in on them thinking more from an accountability lens. So the arrangements have a variety of approaches that they leverage to ensure that their participants are following the technical specifications that they've outlined for exchange. So again, you see participant exchange testing requirements. So two of the arrangements do this. These typically include bidirectional exchange requirements with other live participants and some ongoing component of this exchange, and it typically has to happen in production. And the goal here really is to test the interoperability in a real world setting, right? I think we've seen over the years that just kind of certification, white glove testing doesn't necessarily get us all the way once these systems get it implemented out in the real world. So that's part of what these arrangements are trying to address through these kind of live, ongoing participant exchange testing requirements. Three organizations have certification processes that their participants health IT developers have to go through. A number of the arrangements have onboarding validation processes that they require as you're going live in the arrangement. Some have self-attestation requirements that participants have to go through. And then some of the arrangements have network monitoring that they use to, check a variety of things. Some, for technical, making sure people are following the technical specifications, making sure folks aren't, violating some of the cooperation and non-discrimination provisions. So the ability to monitor network activity to check those sorts of things. So next slide. So a key piece of the more policy accountability aspects of this are network slowdown provisions. So all of the arrangements that support provider-to-provider exchange have provisions that they require their participants to flow down to their end users. And this is really focused on ensuring kind of the chain of trust and the chain of accountability for these policies. That's why specific policies are set here that the arrangements have determined, and the arrangements and their participants have determined need to flow down to their end users to make everyone comfortable with that overall chain of trust and accountability. So while there are provisions that vary across the organizations, there's kind of four that you typically see in the way they've set up their kind of network flow down provisions. So the first is, they require end users to comply with applicable law. So pretty straightforward, HIPAA, state laws, 42 CFR, all the kind of existing and applicable law for the exchange that's happening. The second piece is that the typically slowdown a requirement that end users only access or exchange data for the permitted purposes that are allowed under that arrangement. The third piece is around providing timely breach notification to the arrangement. This is important for the arrangement to then be able to inform other participants and potentially take any actions they need to take in response to a breach. So this is a pretty common provision you see across the arrangement, but again has to be flown down to end users by participants. And the last piece you see pretty commonly across these organizations is a requirement to adhere to the relevant policies of the arrangements. As I mentioned earlier, 6 of 7 organizations have policies that they require, that they have in place that kind of provide additional color under the legal agreement. So they also flow down those provisions through the network slowdown requirements. So again, there are other provisions that these, that kind of one-off in the organizations based on kind of unique setup of those organizations. But these are the common elements that you see across, and all of the kind of network slowdown provisions that organizations have in place are included in the detailed analysis. So next slide. So the kind of next 2 elements that are, essential to any trust arrangement is enforcement and dispute resolution. So all of the arrangements have an enforcement mechanism to address situations where the participants are not following the rules of the road or the technical requirements for exchange. Like all these things, there's a lot of kind of similarity in the general structure and approach organizations have taken. The details vary, the number of days you have to respond to something, or how quickly, how long the suspension period can be. Those sorts of details vary across the organization, but there's a few common elements that you see kind of across the board in the enforcement mechanisms that arrangements have set up. The first is the ability to suspend or terminate a participant for violations of the policies and procedures. And, you see variability. You see there's typically kind of 2 tiers tied to these provisions. If it's a material breach of a participant's legal obligation, there is the ability for the arrangement to immediately terminate a participant. Typically, there is some, just like with the suspension process, there is a time period provided for the participant to cure the breach or the violation and potentially rejoin the organization. But there's typically this provision, if it's a material breach, that immediate termination or suspension can happen. Otherwise, there's typically a kind of more formal process where there's a violation that's not a material breach, so really just kind of a less, and typically the arrangements describe a material breach as going to create a significant risk either to the arrangement or another participant. So for issues that fall below that kind of high bar, there's more of a kind of regimented process where the arrangement has to identify or inform the participant of the violation, and then there's a time period where the participant can develop a plan of corrective action. And if they implement it effectively, they can cure the breach and be reinstated in the arrangement. The kind of third component you see typically across the organizations is that the final decision on an enforcement action, whether it be to suspend or terminate a participant, typically rests with the board of directors or leadership committee. Sometimes there's an intermediate step, some sort of enforcement or dispute resolution committee that receives the kind of goes through the process first. But typically the final say is with the board of directors or leadership committee for enforcement, termination or suspension decisions. The second component of this is a dispute resolution process, another important component to these trust arrangements. And these are focused on addressing disputes between participants, but also for some of the arrangements, the process also covers disputes between a participant and the arrangement itself. So again, you see a lot of commonalities across the kind of dispute resolution process. Obviously, there are, again, kind of variabilities on some of those things I mentioned for the enforcement, different timelines for things, different bodies that initially goes to. But some of the common elements you see across these is they're typically a lot of the times non-binding, or if they are binding, there are typically provisions that exempt government agencies from the binding provisions, because typically government agencies cannot agree to any to be bound by arbitration or other types of arrangements. So you'll see those types of provisions if it is a binding arrangement. And typically the first step of these processes is some sort of good faith negotiation process. If that fails, it goes to the more formal process outlined. And there's variability in whether the kind of dispute resolution process is self-contained, or if it goes to an outside third-party arbiter. So you see variability there, but again, the kind of overall kind of steps of good faith and then moving to the formal process are pretty typical across the arrangements. So next slide. So the last bucket here is the kind of an other category where we tried to arrange a few items that didn't necessarily fit in their own bucket. So if we can go to the other next slide. So there are three categories or three subcategories that we put under here that are of particular interest, I think, for these conversations. So the first is around fees that participants can charge one another for data exchange amongst participants. So you see kind of two general approaches. Three of the arrangements prohibit participants from charging fees for transactions with other participants. And this the kind of within those three organizations, you see variability of whether that limitation or prohibition is tied just to treatment or if it's tied to other permitted purposes. So you see variability there. And then four of the arrangements don't actually have policies permitting or prohibiting such activities. So they're really silent on this, and it's not something that's addressed in their arrangement today. The second piece is around API documentation, and this is really thinking more along the lines of some of the kind of like open API, public documentation of your API. This is not something that any of the arrangements include in their set of requirements on participants today. Obviously it's not necessarily relevant for some of the organizations based on the technical specifications they enable today. But again, I think it's an important part of the the analysis and conversation to understand that this is not a requirement that any of the arrangements have today. And lastly, the bulk access to patient data. Again, this is a use case that none of the arrangements have implemented today. But as I mentioned at the outset, they all have processes to evolve their structures and their use cases and their permitted purposes. So you could certainly envision them evolving to address this in the future, but today none of the trust arrangements address bulk access to patient data today. So that is the kind of summary overview of the detailed analysis. As I mentioned at the outset, it's going to be posted on the healthit.gov/trustedexchange site, so you can dig into all of the details on there. And with that, I will turn it back over to Elise.
Thank you so much, Corey. I do want to take a minute and just thank all of the organizations that worked with Corey and AI in looking at the existing exchange mechanisms that are out there. We said this, I think, from the beginning, but it's even more so true as you look at kind of this analysis and all the different perspectives there, is that we really cannot do this by ourselves. And we recognize that a lot of work has been done amongst our stakeholders, and we look forward to working with them as we go forward on this. So before we go into public comment, a couple of things I want to note. As many know, Genevieve Morris, our Principal Deputy National Coordinator, has been very involved in thinking about kind of the concepts and working with Don on the common agreement. She unfortunately couldn't join us today due to a family emergency. So she's here in spirit based upon all the work we've been doing, but I just did want to note that as well. So on behalf of her, I want to give a little bit of an update on next steps and where we are. So first, as we did with the first meeting, the deck and the materials from this meeting will be available online at healthid.gov/trustedexchange. And not only will that include the deck that you see before you now, but AI has developed a more in-depth kind of analysis of the different kind of networks and how they operate in relation to a lot of the concepts that he discussed in the presentation, but in an even deeper dive. We want to make that available to our stakeholders so that they can kind of see the information that we have, contribute to us, and give us a little bit of more thoughts on their experience and what they've seen as well. So that will be made available, as I said, along with the PowerPoint. Also, I want to invite you to also take a look at the webpage if you weren't able to join us for the first meeting, because in that meeting, we had an opportunity to hear the presentations from these groups themselves, and all of that, the recording, as well as their materials are online. So what's next? So as we've done in our first and now our second meeting, our goal will continuously be to engage and keep the community informed on where we are on things, particularly at our annual meeting, which is coming up on November 30th, will be our next meeting, where we will provide an opportunity for folks to give us some additional thoughts and to engage with us on their thoughts around the TEFCA, as well as provide a status update on where we are. I think we said before that our goal is then to release a draft of what we're thinking about around the TEFCA and encourage public comment on that itself, and then in 2018 to release the final. So as you can see, we're on the earlier end of this conversation, and I think that that's purposeful and strategic, because we do want to make sure we're engaging with the community on their thoughts and getting a good read of where things are and where things can go. And as Don and Genevieve have said in the past, on where the gaps might be. So that's kind of where we are at this point. The next part that we want to provide an opportunity is for folks who have submitted questions online. So we're going to kind of go through some of those questions, provide the answers that we can, where we can. And then from there, those will also be available online. It may take us a little bit, so give us until next week to get these up, as there is, a process to make sure that they are appropriately 508'd, for example, to make them available, but they will be there. Okay, and with that, let me turn it over to Lee.
Thanks, Elise. We're going to walk through the public comments that we've been receiving, and please use your online chat function. We're displaying the slide right now on how to do that if you would like to ask a question. I just want to note first that some of these comments or questions we may not be able to answer at this time, but I am going to read them out so we will acknowledge what we've been hearing. How does the HIPAA TPO exception play into the patient's choice of not sharing data? We will be taking a deeper look at this with our privacy and security team, and we'll be able to share a little bit more about that in the future. We had a question, how about blockchain? I think that is probably a future resource or standard that will likely be addressed through the ISA and the Office of Standards and Technology. We do imagine that the common agreement will be iterative, so it will not slow down the maturation of technology, which is happening so quickly. By draft and then final, did Elise mean proposed and final rule? What about the rule? What would the rule be about, the trust agreement only or nestled in something else?
So I'm thinking that's for me. All right, so there's a couple of parts to this answer. The first is, and all of this sits in cures, so if folks do want to take a look, you can absolutely take a look at some of the sections that are included around Trusted Exchange Framework and Common Agreement. One, we are required to publish on our website and in the Federal Register the Trusted Exchange Framework and Common Agreement that's developed or supported. So that is just a requirement that we actually post it so that the public has it. When I say that we would release it for draft and then final, it would be very similar to what we've done in terms of the public comment process that we did this summer, where we would release online the draft. We would provide an opportunity and a mechanism for folks to provide comments back to us online or submit it in some way that we would identify, and then we would review those comments and release a final. And then the final would have to be published on the website as well as in the Federal Register. there is a component of that is rulemaking, and what Cure says is that for purposes of the Trust Exchange Framework and Common Agreement, that we have to use notice and comment rulemaking to establish a process for health information networks to voluntarily elect to adopt the Trust Exchange Framework and Common Agreement, which basically means that while we would draft and develop the Common Agreement, and that could happen through online and posting in the Federal Register, for purposes of setting up the way in which folks can sign on to it, that has to be laid out in rulemaking. And we are, we are appreciative of that requirement and are working to develop what that process would look like. When that is ready, that would be released in the form of the rule. That does not mean that the entire agreement would sit in a rulemaking, just the process as laid out in Cure. So I hope that answers the question.
Thank you, Elise. Next question, will Corey be providing numbers to support his use of terms such as some, most, a few, or vast majority? The answer to that, we are posting all of the comments online. They will be at healthit.gov/trusted exchange. You'll be able to see there, and it's actually not that hard to sort of see from that how we sort of tried to categorize the some or most or a few in most cases. And
I would note there that, we tried to put together a summary of the public comments just for ease of consumption so folks can get an idea of what we read. But we also do encourage you, we're going to post all the comments online, to take a look at all the comments and see your thoughts on what is in there as well. Because again, in the short time period, we only had the opportunity to do a quick summary and obviously couldn't capture every comment that we received.
Next question, which exchanges have which permitted purposes? That will actually be also available online. It's in the full detailed analysis. That'll also be posted at healthit.gov/trusted exchange. I'll keep saying that. It'll be drilled in by the end of this, especially for us in the room. Next question, was there further segmentation regarding exchange for the treatment permitted purpose and overarching state-based regulations regarding minors' privacy and behavioral health treatment privacy? That will be a piece that we will be working with our privacy and security team on, as well as the Office of Civil Rights moving forward on this, and we will address that at a later date. Where are patients and consumers and family caregivers among these permitted participants? That is a good comment, and we are taking note of that. Please let us know what the various use cases are.
Yeah, so I think, some of these questions, I think when we're reading the question, it's a little bit hard to tell whether you're talking about the summary that Corey provided, in which case that information will be available through the PowerPoint. If they are more forward-looking questions about how ONC is considering some of these scenarios, that's something that we're all open to. So as we receive these questions, we're kind of putting that into our analysis and our consideration of what would be the right balance for as we put together our thoughts on the test cut. So some of these, as Lee said, we're not exactly able to answer at this point, but we're considering these on an ongoing basis.
Next question is a long one, so hang in there with me. Analysis published recently by the HHS Cybersecurity Task Force in the 2017 report regarding the status of the national health IT infrastructure noted that it was grossly unready and even posed great risks. In light of that reality, what methodology will be used to assess and monitor the public health safety of the Cures Act mediated trusted exchange framework? In layman's terms, how will we be sure the network is safe from malware compromise, and how will we be monitoring patient safety instances and issues stemming from the trusted exchange? I think that that's an important note. I think it would be useful to look at the detailed analysis of how the current trust arrangements handle this issue, and we will certainly be taking that into deep consideration as we move forward. Next question. In the July 24th meeting, it was mentioned that the FTC jurisdiction and engagement as it relates to patients and their data. I think I'm reading this correctly. Let me.
So not exactly sure on from how the question is phrased, what the writer's intending to mean, but I do know that, you know, as we look at the common agreement, again, we're not just looking at it in a vacuum. And that means not only engaging with our external stakeholders, but also engaging with other federal agencies as we are developing it, and then also as this would eventually go out and be implemented and hopefully signed on by our stakeholders. So FTC would be, I think, one of those stakeholders that we would be engaging with them as we are developing this and moving towards execution.
Next question, how about the national API by December 16th, 2017 as called for in the Act? I see a bunch of APIs here.
So APIs are a key component that's noted in CURES. It's noted in several different sections. APIs, for those on the line who don't live this every day as we do, application programming interfaces. This is something that I think, you know, Dr. Rucker has talked about as being important to kind of the next stage of where we are in health information technology. And as we think through that at ONC, not only in relation to things like the common agreement, but also in relation to some of the other provisions of CURES, our goal is to make sure that we are engaging with our stakeholders on where they are in the development of that and what we think might be the most effective way to move that technology forward in support of data liquidity.
Next question, what provisions are there for patients to know they are in an exchange and to opt out at their individual participation in that exchange?
So that I believe that's a forward-looking question in terms of kind of how the agreement is going to be set up. I think those are important notes in making sure that we're providing enough transparency in the process for how folks can sign on, but also how folks know who is signed on. And CURES calls that out as well in terms of a list being available of who is a signatory to the agreement. So as we think through the process here, we appreciate that comment, and we'll definitely take that into consideration.
Will the November 30th meeting be a webinar or an in-person meeting at the ONC annual meeting? We will be having an in-person meeting on November 30th at the ONC annual meeting. The registration is now open for the ONC annual meeting, so please register and join us in person. We will be determining if we will have the ability to broadcast it as a webinar. I'm not confident that we will be able to do that from this venue, but if budget allows, we will certainly try. Will ONC be issuing a reg or RFI?
So I'm guessing that's in terms of the process. So it calls for notice and comment rulemaking. So in order for us to finalize the process that's called out in CURES, we would have to go through notice for proposed rulemaking, which would be a rule, I believe, was the phrasing of the question.
Next question, were any data collected as to the overlap in membership in these 7 organizations? In other words, for a given provider or payer, how many of these organizations did they participate in? Do many providers and payers belong to multiple trusted exchanges? That is a good question. We did not count the overlap there. However, because there are some distinctions between these organizations, there are many stakeholders that are members of multiple organizations because they provide different services, of course. And I think that'll be a little bit more clear what those distinctions are in the full detailed analysis online. Next question was, any analysis performed on participants of the 7 organizations to determine if vendors or HIOs were blocking information, i.e. versions of vendor applications not compatible and variations in business rules between HIO communities? I think that's something good for us to take a look at. I do not know that we perform the analysis in that manner, but we will go back and take a look.
Yeah, it's Don Rucker. We're really seeing the CURES Act by law and by fact and by goal as a go forward type of thing. So we're not really focused. You know, I think everybody who's been in the interoperability games had to start somewhere in some way with some type of process and have some starting point. So we're really looking at this from a go-forward basis and have neither legal rights nor any plans to really delve into past things here. It's really, as the law says, sort of the 21st century.
Will ONC staff be drafting the TSCA in private? Any drafting that's done will be subject to a public comment period and review. So it will be out for review through our normal process. What were the criteria for selecting the 7 organizations of focus, and were the comments submitted by states with highly successful statewide legal frameworks considered or not? The answer is that we were looking for organizations that enabled trusted exchange across multiple and disparate networks, and sort of how those were arranged. I think from the state perspective, we did very much taken SHEIC into account and worked very closely with the team there.
You just spell out SHEIC.
Yes, SHEIC, the State Health, Strategic Health Information Exchange Collaborative. Yes. Which are the state HIEs in most cases.
And I would also add that if folks are aware of other folks that we should talk to who are involved in exchange across disparate networks, we are always open to that conversation.
Yeah, Don Rucker again. I mean, we have heard some sort of informal sense that there may be some other people who are looking at these things, and we expect that very well might happen. And in fact, from an open market consideration, are trying to have all of our rules and regulations engender as much participation and competition as we possibly can. We started with the folks who've already been doing significant work in this space, as to the question of how we came to the names.
What is the definition of bulk download that it seems none supported?
So again, Don, the population level analyses of these data sets right now, I think our general focus historically has been regarding individual patients. So provider A gets information on one individual patient, provider B. From an economic perspective as a payer, from a population health perspective as a vendor, and in many cases from a public health perspective. For example, the Center for Disease Control spends vast resources looking at public health information, and obviously with all of the natural disasters that we've all hopefully not experienced, but in some cases have experienced, and I think in all cases have seen, having access to some of this data in a HIPAA compliant way, where the query is for a number of patients greater than one, is important from institutional accountability, from open APIs, right? That's what open APIs, in fact, in many, many cases throughout the economy do. And you might ask, so what happens now? In a lot of cases, it is too complicated to get the data, so we don't get that benefit. In many other cases, there are one-off, expensive, point-to-point contractual agreements where each data element is basically negotiated individually. The important part of that is we collectively as a country pay for all of this, right? These things are not free. Somebody pays for all of these individual things. From a patient and a consumer and a public citizen point of view, these things make it a challenge for any interested HIPAA authorized third party to actually see what they are getting when they pay for healthcare. Most healthcare in America is purchased by large payers. whether you like that or not, that's, I think, the reality. And, obviously, with high deductible health plans, more of it is shifting onto individual purchase decisions. But as we speak today, the vast bulk of care is purchased in, at the population level, as opposed to your own individual level. And at that population level, we want to have some of the same open API technologies that exist elsewhere. So that's, I think, the answer when we talk about these types of analyses. I would call out, some of this is already done today. A lot of these things can be very standard relational database queries. We're working with HL7 on some of the back-end FHIR services, which is sort of a technical term to look at, what other things might be done to do queries larger than in. Let me close. Every one of these things is already a permitted purpose under HIPAA. We are not allowing any additional access to any patient record or any, breaching any security mechanism or any privacy mechanism that exists. In fact, this will probably lead to more privacy and security than all the one-off interchanges that are going on now, which by their very brittle nature entail both privacy and security issues, as well as issues on how do you log the data and the whole range of lack of transparency issues.
The next question, any analysis of how these all supported audit logging to support accounting of disclosure and privacy investigations? There will be some information on that in the detailed analysis that will be posted online. Next question. So we are trying to build a new INHIN. This is distinctly different, I would say, from the INHIN, as maybe the only person who was here during the INHIN days, because this is a framework and agreement to exchange across networks that are created by external entities. When purpose of use of treatment is used, is it implicitly inclusive of operations and payments?
We're not changing HIPAA.
Right. So
I'm not clear exactly on the question, but as it relates to HIPAA. But HIPAA, as you know, is led by the Office of Civil Rights here at ONC, and as we're developing the common agreement, we've been in ongoing conversations with them on potential elements of the common agreement that would relate to privacy and security.
So the HIPAA provisions remain intact without change.
Yes.
There's nothing here that changes anything with HIPAA.
Right.
Which amongst other things means, all the contractual, all the legal frameworks that HIPAA supports remain as they are. People may say, please use this network or that network, but in terms of the mechanism, but the actual exchange is totally governed by HIPAA.
Are you aware of the Oshera Vista work regarding FHIR, and the link was included? I will pass that forward to the Office of Standards and Technology. Was permitted use covering regional emergency natural disasters evaluated? So when we have a natural disaster or emergency like the hurricanes, we often work at HHS sort of hand in glove with the states to make sure that they are given the appropriate waiver under the level of disaster declaration that they need to make sure that care is available at the point of need. So we did not evaluate that specifically for the common agreement because those are really done on a case-by-case basis and are oftentimes contingent at the point it's declared a disaster by the president. Karen said the FTC has jurisdiction, HIPAA does not. That's a comment that we will take forward. do you acknowledge a HEMA IGAM validation for policies and for your agreement? We have worked very closely with HEMA through this process and will continue to do so. What is ONC's position on HL7's FHIR as a viable single EHR API? That is really something that we will take forward to the Office of Standards and Technology. Have you considered other industry segment models for insights, for example, telecom, no single standard, and the other unique standards if switching carriers? We do of course take into great account the way the market has developed around different technologies, including telecom and banking, into account here to make sure that we're trying to create this in the most seamless way possible. And we will continue to do that going forward. Network of networks. State HINs connect multiple and disparate networks and are not considered full members of SHEIC since the ONC-funded states like this. Will their successful frameworks be considered? The answer is yes. Anyone who is exchanging data will have the ability to exchange in a higher realm to connect. We are still working on how that flow down happens, but we would strongly encourage existing networks to hang with us as we go through this process and make sure that we figure out just the right place to plug in. Michigan Health Information Network, MyHIN, is a statewide HIE with multiple local HIEs. Should be considered. Same answer for that one. We will be looking strongly toward that. What will the role of high-tech be in the development and finalization of the test guide?
High-tech, right?
High-tech,
okay.
I'm sorry.
With high-tech, the advisory committee, and high-tech, we always have to be careful in our enunciation here,
yeah.
Which we're learning. So to explain that, high-tech is authorizing statute for ONC that goes back a ways now. High-tech is the Health Information Technology Advisory Committee, and I believe the nature of the question. So the Health Information Technology Advisory Committee is the new advisory committee that Congress has set in place for ONC to address forward-looking health information technology issues. We have sunset the previous two committees, which are the Health Information Technology Policy Committee and the Standards Committee. The new HITAC is responsible for looking not only at policy issues around health information technology, but also at standards-related issues. And we are in the process of standing up that committee, and our goal is to move that committee forward in winter, this upcoming winter. Our goal is to have the common agreement go before the HITAC for them to look at components of it, and to receive their feedback. I think, Congress was very clear of the importance of the HITAC and the advisory committee in the development of health information technology policy. And as always here at ONC, we agree and we look forward to engaging the HITAC and the common agreement development.
Next question. There was a question of others involved in HIE, HRSA-funded HCCNs assisting FQHCs with state HIE. We will, of course, we are working with our federal partners here and all of the supports that they have in the ecosystem as well. Next question. Generally, most but not all exchange involves encryption. HIPAA final recognizes BAA types of exchange, which require things like DURSA, because the encryption is not end-to-end between use case actors. End-to-end is considered by HIPAA OCR to be a conduit like FedEx. No BAA required by law. End-to-end cannot by definition look inside packets, aka DPI, to evaluate content. So we need to look at identity very closely, like directory, and a defined container like the CUF to enforce policy. We already see this working at Federal Bridge in which there is policy. We will be working, of course, with the parts of this that fall into standards and to our privacy and security team to ensure that we are aligned. And thanks for this good comment. Would the bulk data collection via API also be used to gather data from the claims that payers hold?
Right now, I think that the focus of cures is really on clinical data. That is really the focus of cures, and that's where the starting is. The commercial data is something that is not currently, as we understand it, covered under cures. I think we'll say in passing, though, that obviously as HHS, we're extremely aware of some of the national concern on things like price transparency, the ability to have markets here, some of those things. So, I think there's a broader national, again, Don Rucker speaking, there's a broader national discussion about how we have some more price transparency in the entire healthcare system. So I think that is an ongoing process for national discussion.
Next question. My question overlaps with a prior question on use cases. How is the scope for TEFCA defined? In addition to use cases, which primary stakeholders are included? Providers, patients, payers, government agencies, public health agencies. I'll take the second part first. All of those stakeholders are included as we are thinking through this. The scope of the TEFCA, we're really taking it very much from the cure statute and following very closely with what the request of Congress for ONC to do within the specified time frame here. Will there be an analysis of Medicare, Medicaid, and the VA program participation in the framework? The answer to that is we will, of course, be working with our federal partners at CMS and at the VA to ensure that is working. In the Cures Act, I know it speaks about information blocking. How do you plan to address that? Are you going to define it further to provide more clarification? That is I'll turn that to Elise, but that's probably more of just a comment that we take.
Yeah, I think so. I think we take that into consideration. I think Congress went to really focus on different components of the health information technology environment that can impact data liquidity and the movement of information. And we do recognize our, responsibility to consider all of those pieces as part of the puzzle of moving things forward.
Seems the newly defined bulk download is an unfair measure to place after the fact. There are standards for this. They simply have not been asked for in the USA. For example, in the IHE XC, there is an MPQ developed for this use case.
Well, I think evolving these standards and evolving them over time with adequate time for people to implement them is absolutely part of this public process. That's why we have these comment periods. I think we're sensitive to the fact that, different standards are in different states of evolution, and we plan to have, rulemaking reflect what a number of things, including the maturity of standards, both specific and general, the time it takes to program compliance with these standards in a way that is robust and, meets all the privacy and security and reliability issues, and the time it takes to install new versions of software at the practice level, at the enterprise level. And so there is a significant timeline to these things, and we're aware that there is that significant timeline, which means that, we have to work through all of those considerations, and will.
Next question, do NIST standards for privacy and data exchange take precedence over other data exchange proposals?
Don again. We're certainly mindful of, the standards NIST put out. I think when we look at a lot of this sort of global, if you will, cybersecurity, this is a global problem, right? I mean, the people who are attacking our healthcare networks are coming from all over the planet. And, the goal is to have a regulatory framework on this that supports modern best practices of cybersecurity. That is, unfortunately for all of us, a rapidly evolving standard. We just want to have globally, the global state of the art on these types of things. That, of course, makes a lot of stuff like no special effort quite a challenge, right?
Next question. Are you working with ENAC, the Electronic Health Network Accreditation Commission, regarding potential accreditation rules? We will certainly take that into account and share that with the entire team. Next question. When is HITAC beginning its meetings?
Our goal is to start up the HITAC in winter. So I think we're getting close. There are a number of kind of administrative components that we have to do to make sure that it's set up and it's in compliance with the Federal Advisory Committee Act. All of that is underway, but it's definitely a high priority for us. We look forward to the feedback that they're going to provide. So we're working on it. We're not quite there yet, but we're getting closer.
What federal agencies are projected to participate in HITAC?
So in the past, we've always had diverse federal agencies involved, and we're always open to working with our federal partners. Folks in the past who have been involved have been CMS, for example, VA, DOD. So those are the folks who tend to have, obviously, working a lot in the health information technology community. In terms of the exact list, we have to work with federal agencies, so we wouldn't be able to announce that at this time.
The final comment we have, or well, almost, until I said that, the presentation seems focused on query-based types of exchange. There is a tremendous amount of exchange occurring across the country that is push-based exchange, such as results delivery, notifications, direct transitions of care. Will this framework address all types of exchange? The answer is yes. We will be taking a look at all types of exchange as they feed into networks and into the entire ecosystem. You'll notice that Direct Trust was one of the organizations that was a part of the analysis, so we do want to make sure that we represent all types of exchange. How will you integrate research efforts in the framework?
I think we received some comments on that in the process. We're looking at that in terms of research as well as kind of the other potential uses. I don't think we have a decision at this point, but we look forward to keep on receiving comment in that space.
A good way to improve health is to keep people healthy longer before they require sick care. This will involve exchanging data between patients, social data, and population health managers at agencies like Census and CDC to cooperate and to deal with opioid crisis. That's a very good comment and something we were thinking a lot about as we move this forward. So that is all we have received. So with that, I will turn it back to Dr. Rucker to close for us. I got one more quick question. Will there be a similar public comment period on Cures Act Section 4006 interoperability? I'm not sure what part of 4006 that you are referencing. 4006 is one of the areas that involves us working with the Office of Civil Rights. We'll go back to them and talk with them a little bit about that, but I'm not sure exactly what part of 4006 you're referencing. There's a number of them, so feel free to shoot us an email and we can follow up.
Yeah, I think first of all, Lee and Elise, thank you very much for live feed handling. Michelle here behind the scenes is our studio cinema verite director of this. And really, mostly, thank you to everybody who's listened, everybody who made the effort to put in comments. I think the quality of the comments was superb, and we're trying to run as transparent a process on this to get us all healthier at a lower cost, as is the intent of our elected officials. And with that, I think we're going to thank everybody and close it. And I think we've outlined some of the future steps. And sounds like healthit.gov is the website to go. So thank you very much, everyone.